chair. It's my great privilege to introduce Dr. Geetha Sivasubramanian, who is an associate professor of medicine at UCSF Fresno. Dr. Sivasubramanian is also the program director there of the ID Fellowship Program and the division chief. Dr. Sivasubramanian is joining us today to talk about Chronicles from the Central Valley and talk about challenging cases in Cocci in people living with HIV. So we are so glad you made the journey here today, and thank you so much.
All right. Thank you, Liz. Good morning, everyone. Hear me okay? All right, perfect. Thank you so much. I'm super thrilled and honored to be here to talk about challenging coccidiomycosis cases in patients with HIV. And thank you for the opportunity. So my goal today is to kind of make a case to understand the nuances of various coccidiomycosis diagnosis tests, particularly in immunocompromised hosts such as patients living with HIV. Identify severe complications of Cocci in immunocompromised hosts, a few of them at least, and review some strategies to prevent Cocci in persons living with HIV. So I'll go on to my first case. The details have been modified to protect the patient's anonymity. So this is a 39-year-old Caucasian trans female, unhoused, has a history of HIV that was diagnosed in 2016. She was not on HAART for many, many years. Presented in August of 2021 with a 2-day history of worsening shortness of breath. Just a little bit of history about her, pertinent background history. She carries a diagnosis of depression, anxiety. She's been treated for syphilis before. She's been diagnosed with HIV, and I'll give some history about her HIV shortly. She's never had any surgeries. There was no pertinent family history. She did have ongoing social issues. She had ongoing substance abuse problems. She smokes methamphetamines, marijuana, smokes cigarettes. She denied any IV drug use. She was unhoused. And she was not recently sexually active, although previously she was, and she prefers men. No travel, no close exposure to animals or birds. She was not taking any medications. She had never been on any gender-affirming hormone therapy or had any gender-affirming surgeries either. So as far as her HIV, she was diagnosed in 2016 with acute retroviral syndrome. So at diagnosis, her serology was negative. She had more than 10 million copies of HIV RNA. Her CD4 at the time of diagnosis was around 340 cells, 28%. So she was started on Triumeq. She was on it for the first 2 years and went on to have an undetectable viral load. And her CD4 went up to about 1,040%. But unfortunately, due to ongoing social issues, unstable housing, she stopped taking medications from 2017 and did not follow up for her scheduled appointments. She did come to our specialty services HIV clinic in 2018. She had been off of medications for more than a year at that point. She showed a willingness to resume medications. However, she remained non-adherent and did not even get her labs done. Same thing happened again the year later, 2019. She came up, but she never followed after. So no known opportunistic infections. And then after this, she was off the radar for a couple of years until she showed up in the hospital. So her first hospitalization was in June of 2020. She came in with fevers, chills, body aches. She had shortness of breath. She had chest pain. All of these were going on for about two days. The chest pain was pleuritic. It was radiating to the back. She was febrile on admission. And that chest x-ray, and I'll show her CT, had a right upper lobe infiltrate. By this time, her CD4 had dropped to 10%. She was seen in the emergency room. She was admitted. She was started on CAP therapy. Blood cultures and her CAP workup came back negative. And unfortunately, she left against medical advice within 2 days of that admission. So this was her CT chest that was done during this admission in 2020. And you can see that right upper lobe mass-like opacity, fairly big, about 3.5 by 3.5, 2.5 centimeters. Now, at this time, coccidioides EIA test, which has a quick turnaround time, was not ordered. They directly ordered the UC Davis complement fixation immunodiffusion test, which takes time to come back. And the patient had already left before the test could come back. And her CF was negative, and her immunodiffusion was equivocal. She did have a high beta glucan. This also came back after discharge. And she had a urine histoplasma antigen test done that came back negative, but after she was discharged already. And so with this CT, with this labs, she left against medical advice. So I will pause here for a question. I don't know if we have audience response enabled for this. Okay. So if this patient had stayed in care at this point, what would be the next best step in the management of this patient? One would be repeat the cocci serologies in 2 to 4 weeks, but don't start any treatment. 2, obtain a bronchoscopy, try to get biopsy and cultures. 3, obtain bronchoscopy, biopsy, cultures, and also started on empiric fluconazole. 4, obtain bronchoscopy, biopsy, cultures, start empiric fluconazole, but also plan to repeat the cocci serologies in 2 to 4 weeks. Okay. Oh, there you go. Perfect. All right. Yep. Most of you got it right. And I'll come back to this on the strategies on how the diagnostic tests work. And I'm going to go forward a little bit about the patient's history, and we'll come back to this question at the end of the case. But I think most of you got it right. So she was off the radar for the next year. So she came in, she left against medical advice with that CT and didn't show up to care until next year when she presented with a 2-week history of nausea, vomiting, anorexia, fevers, and chills. She also complained of severe night sweats, which soaked her clothing, as well as an unintentional weight loss that was going on for several weeks. She had fevers during her entire hospital stay. And she did have chest and abdominal imaging done, which were abnormal, and I'll show those images. And again, unfortunately, before her workup could be completed, she left the hospital against medical advice within those 5 days. So this was her CT done, this admission in July. And as you can see, that right upper lobe infiltrate that she had before was mostly resolved. That area of dense consolidation had mostly resolved. At this point, she only has some residual scarring there, which shows up as some tiny nodules on the other side. There was some bronchial wall thickening, but otherwise the chest CT had improved compared to the previous year's CT. She did have an abdominal CT, abdominal pelvic CT, which showed significant hepatosplenomegaly, as well as retroperitoneal and pelvic lymphadenopathy, which the radiologist commented was suspicious for a process such as lymphoma. So now she comes back 3 weeks later in August with progressively feeling much worse. Now she's short of breath, she's dizzy. Her fevers never went away since July. She had been febrile, she was having weakness, dizziness, nausea, anorexia. All of this persisted since her recent hospitalization in July. And now this new onset, sudden shortness of breath for the last 3 days. It had progressed to dyspnea at rest. So she came into the emergency room very acutely ill, tachycardic, tachypneic, in respiratory distress, and had to be intubated immediately. She was also progressively hypotensive with lactic acidosis, requiring pressor support. So this was her exam in this current hospitalization, August of 2021. So 2020, she had that lung infiltrate, and I'll show the imaging. 2021, July, she came in systemically ill, but the CT was better. But now she comes back 3 weeks later with severe worsening shortness of breath, and her exam, she is acutely ill, she's tachycardic, hypotensive, tachypneic. She was already intubated and sedated by the time ID team had seen her. Coarse breath sounds throughout her lung fields. Her abdomen was also kind of firm and distended. She had diffuse peripheral edema in all her extremities. No lesions or rashes were noted. I'll see if we can play a video. And that's her CT chest now in August of 2021. Okay, so as you can see, significant bilateral throughout all fields, interstitial infiltrates with a miliary pattern there. And she also had some bilateral pleural effusions and some pericardial effusion as well, if that's visible there. Okay. All right, so that's the evolution of her CT findings. So in June, she had come in with that lesion there, had left against medical advice before any of her workup could come back. She had that right upper lobe mass-like density. When she came back in July, she was systemically ill, but her lesion in the CT had improved. And then by August 2021, her symptoms had progressively worsened. Now she has new onset, severe shortness of breath requiring intubation. Plus, she's systemically ill, hypotensive, lactic acidosis on pressor support, and now her CT is looking like this. So what is the likely etiology of this most recent CT chest findings and the ongoing clinical syndrome of profound shock, respiratory failure, hepatosplenomegaly, and adenopathy? Miliary and disseminated TB, miliary disseminated cocci, miliary disseminated histo, ARDS and HLH secondary to lymphoma, or is this a co-infection with cocci and one of the other opportunistic infections mentioned here? So kind of have a split between disseminated cocci, disseminated histo, as well as the possibility of co-infection, but majority going for miliary and disseminated cocci. So these are her labs. So when she came in June, she did have, her CD4 was at about 118, 10%. She had an equivocal cocci immunodiffusion, but a negative complement fixation. In July, we had these labs where the patient had left already against medical advice. Her CD4 was down to 36 and 5%, and her cocci immunodeficient was strongly positive with the cocci complement fixation titer of super high at 1:256. And she was already having some signs of renal failure, some evidence of systemic infection from this. When she came back in August, her CF titers were up to 512. At this point, she underwent more workup. So she had a bronchoscopy done, and the bronchoscopy cultures were positive for cocci. Her PCR was positive, and her fungal blood cultures came back positive for cocci immitis, which I'll show in a slide later, is extremely uncommon. Even with very severe disseminated cocci, we actually don't see patients coming in with fungemia, and usually has a very, very poor prognosis. So I'll talk about that a little bit. And so her cocci CF titer came back at 512. And we did do an LP given that significant high titer, even though the LP was normal again, which is a bad sign when they have this amount of significant high levels of cocci, but their LP shows normal cell count. That means her inflammatory syndrome is so high that she's not mounting a response. We typically see that the prognosis again is worse when they have a normal cell count like that. Her cocci CSF in the CF titer in the CSF was 1:4. So she was started on broad spectrum antibiotics. She got liposomal amphotericin B right at the presentation because we knew her labs from July. So she went into profound refractory shock, needing escalating amount of pressors, stress dose steroids. At this point, we assumed that her adrenals were involved as well, causing the profound shock. But eventually, due to lack of response and poor prognosis, she was transitioned to comfort-directed measures only, and the patient passed. So this was a fatal disseminated fulminant miliary coccidiomycosis with fungemia in a patient with advanced AIDS. I just wanted to kind of highlight a few things about this case before we move on to the next case. The patient's substance abuse and mental health, as well as having unstable housing, were major challenges in retaining her in care and managing her HIV. So despite being diagnosed very early, she was diagnosed with acute retroviral syndrome. She was diagnosed very early. She could not be retained in care, leading to advanced immunosuppression and the complications related to that. Now, not only in persons living with HIV, what we see in Central California is we do have a lot of problem with access to care and retention and care for all patients with cocci, especially our rural migrant farm worker community. So, and with our patients who have substance abuse and mental health and housing issues, it adds a second layer. And patients with HIV and cocci, again, it adds to that second layer where it becomes very hard to retain them in care and follow them. The other important issue here is we don't have a sensitive point of care test for rapid diagnosis of cocci. For instance, when she came in June of 2020, granted, she did leave against medical advice. It's hard to say how she would have been adherent to her care. But ideally, the emergency room should have had access to a point of care test to Cocci, where she could have been diagnosed early and started on treatment early, especially since her CD4 count was less than 250, which would be a major indication to start her on treatment. There is a lateral flow assay test, and I'll talk about the lab test, which is available, which is sort of a 1-hour turnaround test. But the sensitivity of that is only 31% in a study that was done in Arizona. So right now, we don't have a sensitive point of care test for rapid diagnosis of Cocci. So we rely on the EIAs. And in the initial phases of infection, the EIAs, the immunodiffusion, as well as the complement fixation can be negative, especially in immunocompromised host. And retesting as well as empiric treatment becomes important to avoid delays in diagnosis and treatment. So these are some of the tests that are available to diagnose Cocci, and I've not mentioned the main one, which will come in the next slide, as a serological test. So outside of serology, these are the tests that are available. So we have culture microbiology, histopathology, molecular methods, antigen testing, and skin testing. Skin testing was previously used for epidemiological purposes to identify patients in endemic areas who have been infected already. For practical clinical management, the skin testing does not have a role right now. The others do. But immunological methods are the most commonly used ones, and I'll talk about them in the next slide. Just briefly about the non-immunological methods. So cultures, whether it's from clinical samples like BAL, CSF tissue, and rarely blood, may be the only method where you can diagnose Cocci early on. So the first about 3 weeks or so, especially in immunocompromised patients who are severely sick, serology may be unreliable, so we have to rely on culture from clinical samples. However, if you have a patient that's not very sick, they have mild infection, they are not producing sputum, they don't have a tissue that can be cultured or biopsied, we have to rely on serological tests to make the diagnosis. Same goes with histopathology. Under pathology, we typically see spherules. In severe cases, hundreds of them, each capable of propagating infection. Again, you need to have that tissue available for pathology, which is usually the case in severe cases and in immunocompromised hosts. If you have a mild infection, it may not be feasible to do histopathology and cultures. We don't use the next one that's available is the coccidioidal antigen detection. We use it minimally in our center. It is available for testing from blood, urine, and CSF. Seems to be more sensitive in immunocompromised host. Molecular methods are variably available. Some centers have and some centers don't. We have a locally developed PCR that we do use for our patients, and it has a good specificity but variable sensitivity, especially from CSF and pleural fluid. So the sensitivity can be as low as 50%. There are other non-specific markers like beta-glucan, again, may have low sensitivity, but if you combine that with other methods, may be helpful in the diagnosis. So bottom line is, if you have a patient that's very severely ill and is immunocompromised, early on especially, serology may be unreliable. So we want to try and use these methods, whether it's antigen detection, molecular methods, culture, or histopathology. Otherwise, the most commonly used method for diagnosis of Cocci is serology. So the main ones are the enzyme immunoassay, immunodiffusion, and complement fixation. The problems with these assays, as we could see in our case, is early on, in the first few weeks of the infection, especially if they are immunocompromised, these can be negative because the patient has not had a chance to mount a response yet. So if you can see day 0 of infection, and about 1 to 4 weeks is when symptom onset is happening. At this point, the best way to diagnose is by culture, PCR, histopathology. Cocci IgM takes about anywhere from 7 to 21 days after symptoms begin to turn positive. IgG is typically detected by immunodiffusion complement fixation around 21 to 35 days post-illness, and the maximum CF titer reaches about 21 to 70 days post-illness. And then it starts to wane down. And as the acute illness resolves, all these tests can turn negative: EIA, immunodiffusion, complement fixation, all of them. In some patients similar to syphilis, you can have a serofast complement fixation where it remains a low positive for life. But if the patient doesn't have ongoing clinical illness, we wouldn't treat them. So EIA again, these are the three main tests, the EIA, immunodiffusion, and complement fixation. If you have a measurable anticoccidial antibodies, it usually represents a recent illness or an illness that continues to be active. Antibodies usually decrease over time and eventually become undetectable in most patients who resolve their infection. And the main issue is it's less sensitive in the first few days to weeks of the infection. So the first 3 weeks or so, it is less sensitive, and it is less sensitive in immunocompromised hosts as well. So we want to remember that and retest those patients if this clinical suspicion is high. EIA should always be the first test ordered. It has the most sensitivity compared to the other serological test. Immunodiffusion test should be performed as a confirmation test when the EIA is positive. The turnaround times are better. Most of these EIA tests are locally available. And the only caveat is sometimes the IgM EIA is prone to false positivity. So we address it based on the clinical syndrome. And the sensitivity can be as low as 67% in patients who are immunocompromised. So if you have an immunocompromised individual, patients living with HIV, advanced immunosuppression, you want to use multiple diagnostic methods, including antigen detection, cultures, biopsy, and retest the patients as needed, which most of you in that first question had appropriately answered. You want to get biopsy, cultures, and also retest them in 2 to 4 weeks. And because the clinical suspicion was so high, given the previous CT scans, that patient has advanced immunosuppression, we do want to start them on empiric treatment as well. Immunodiffusion should be performed whenever an initial EIA is positive. Sometimes the nomenclature can be a little bit confusing, but IDTP typically refers to immunodiffusion assay that's used for IgM. IDCF refers to the immunodiffusion assay that we use for IgG. These are less sensitive than EIA. That's why we don't want to start with these. We want to start with the EIA and use them for confirmation. They are less sensitive, but they are more specific. And this is an example of how an immunodiffusion gel plate looks. So we see the antigen and antibodies in different wells of a gel plate diffuse and form these visible precipitation bands. So you have a qualitative immunodiffusion, which can be followed by a quantitative test. But for the most practical purposes, the quantitative test that we use is the complement fixation. And complement fixation should not be used for diagnostic purposes. It's used for prognostic purposes. It's the least sensitive amongst the serological tests. And about 25% patients with pulmonary cocci, they never mount a CF response. So we cannot use it to confirm a diagnosis. We use the immunodiffusion to confirm the diagnosis, and we use the complement fixation for prognostication. So the higher the complement fixation level, the more the antibody response, the more severe the illness. So this is so you're able to quantify the antibody response to illness. So the test, of course, relies on the properties that complement binds antigen antibody complexes. And if you have an antigen antibody complex forming, the complement is bound, so it's not available to lyse red cells. So here there's a lot of antibody present. So the antigen antibody complex is bound, so the complement is not able to lyse. So when you do serial dilutions, by this time, the complement is free. There's no antigen antibody complex left, so it's able to lyse the red cells. So we're able to actually quantify the amount of antibody present. So typically when we see complement fixation titers about 1:32, we start to worry that the patient may have disseminated infection at this point. But that number is variable. On an average, around 1:32, we see that. We have seen disseminated infections at lesser levels of complement fixation too, but around 1:32 is when we really start to worry about dissemination. So when we have a clinical suspicion for cocci, we want to try and obtain culture histopathology as much as possible. This is possible when patients are severely ill, or if they have disseminated infection, either skin, bone, CSF, so we can obtain cultures from there. But if they don't have severe infection, they are not immunocompromised, then we may have to rely on serological methods, but understanding that serological methods have some nuances to be taken care of, to take it with a grain of salt. So the first test that we would order is an EIA for IgM and IgG. If that's positive, then we confirm it with immunodiffusion, and we prognosticate it with the complement fixation. If it's negative, we either consider an alternative diagnosis, or if the concern remains high and we don't have any specimens to culture or do pathology, we retest the patient in a few weeks to see if they mount a response later. The LFA, as I mentioned, is available, but it has a very poor sensitivity, about 31% in a recent study. So we rather would rely on EIA, so we don't do LFA for our first-line testing at this point. Immunodiffusion, again, very specific. It's a confirmatory test for EIA. And if it's positive, we test the complement fixation to prognosticate. If it's negative, again, the sensitivity may be low in the initial periods and in immunocompromised hosts. So if the concern remains, we consider repeat testing in about 2 to 4 weeks. So that's about the diagnostics. I also want to point out a little bit about coccidioides fungemia, which is extremely uncommon and associated with a very high mortality. So unlike disseminated histo, so we do see disseminated histo in our patients living with HIV who have AIDS, and it's the syndrome of disseminated histo involving the reticuloendothelial system, liver, spleen, adrenals, retroperitoneal syndromes. Fungemia is not typically seen with cocci. It's very uncommon to see disseminated cocci behave like that. It does not behave like histo to where it gets into the blood, gets into the liver, spleen, bone marrow, adrenals. When it does do it, though, it's usually pretty high mortality associated with that. We did a study in our center, and we are a referral center with high amounts of cocci patients seen. And within our center, during a 10-year period, we only identified 11 cases of fungemia. So it's fairly rare. And previous reports also, single center reports usually are about 11 to 20 cases of fungemia in those 10 or 15-year periods. So most patients in our cohort had an acute infection. So fungemia was seen as part of the first infection, not as part of relapse, but they were actually seen as part of acute infection. And they typically had rapid progression of disease and death with a very high mortality. So 82% of those 11 patients in our study had died. Previous studies that reported these fungemias were done in the early 80s to 90s. So a lot of them had a large cohort of HIV/AIDS patients in them. Our cohort had only 27 patients. They were more recent studies, so with more better control. We still have a lot of opportunity to improve our HIV care with the patients retaining in care. But in our study, only 27% of those patients had HIV/AIDS. All right, so I think I'll move on to the next case unless we have any questions from the first case. We good? Okay. All right, so our second case, it's a 21-year-old female with past medical history notable for schizophrenia, PID, and syphilis. The patient was newly diagnosed with HIV during workup for her pelvic inflammatory disease by OB-GYN. And she also had an early diagnosis, I would say, because her CD4 was 761, 30%. Her HIV RNA loaded diagnosis was around 26,000 copies. So at that initial HIV clinic visit, she had complained of a dry cough for about 2 weeks duration, but overall she was feeling very well. And so she was started on Biktarvy. 1 week later, she presented back to the clinic with a new onset rash. This was a diffuse erythematous rash on bilateral forearms, trunk, back. It was extremely pruritic. She was itching to the point of bleeding, and some had left some scars as well, and she was having some chills too. Sort of a representative picture. I don't have the full extent of the rash, but similar to this, but across all her forearms, trunk, rash, and back. What is the likely cause of this rash? Is this an immunological reaction? Is this an allergic reaction to the ART that she was recently started? Secondary syphilis? Is this disseminated cocci, or is this contact dermatitis? Great. Wonderful. That's great. So I'll come back to this question. What happened to this patient was it was thought that this could be an allergic reaction to her ART. So her ART was switched, and she was taking her medications. I think she was switched to dolutegravir and Tivicay, but she didn't come back to the clinic. So she presented 6 months later to the hospital. So she came in with dizziness and weakness and a wobbly gait for the last 4 weeks, along with chills and nausea and sweats. When she was seen in the hospital, she was slow to respond to questions. She did not provide much in terms of history. She did not give a history of having any headaches or any ongoing pulmonary symptoms. She was taking her ART, even though she did not follow up in the clinic. And these are her other medical history we already talked about. She had schizophrenia. She had been treated for syphilis and HIV. She was living with her parents. She had had multiple male partners before her HIV diagnosis, but none since. She had lots of pet animals, dogs, cats, birds, turtle, fish, but no drug use, no substance use. So she was tachycardic. She was febrile to 102.8, but she was not hypoxic. She was saturating well on room air. She's not hypotensive. She's slow to respond. She's oriented times 2, but she's definitely for her age, she was not answering questions appropriately. She was slow. And on exam, she was found to have severe bilateral lower extremity weakness. So she had a strength of about 1 out of 5. Her upper extremity strength was maintained. Her CD4 was 337, 28%. So even though the number had dropped to 337, her percentage was still good. So she was around 30% at diagnosis. She's around 28% right now. Her viral load was undetectable, and her CBC and CMP were unremarkable. Her liver, kidney functions, electrolytes were normal. So this is her. She did not have a chest X-ray done 6 months before. She had had a little bit of that dry cough. I don't know how long those symptoms lasted, but this is the current chest X-ray. Current chest X-ray looks clear, but the CT does show this left kind of middle lobe lesion that is pleural based. She did not have any pulmonary symptoms, even though she had that CT finding. This is her current hospitalization. So she had a lumbar puncture done, and her opening pressure was elevated at 33. And she had 835 WBCs, predominantly lymphocytes. Her CSF glucose was low at 11. Protein was elevated at 1,376. And you can see the significant hydrocephalus on the CT with the transependymal flow. And this was her MRI. And so you can see changes around the ventricle, significant leptomeningeal enhancement and thickening. And you can also see that the ventricle size is fairly large with significant ventriculomegaly. So again, a lot of leptomeningeal thickening as well as hydrocephalus, but we don't see a focal ischemic area. Although I don't know if it's clearly visible in this view, the significant thickening was actually encasing in this area, encasing her major arteries as well. Okay. So it was reported as throughout significant diffuse leptomeningeal enhancement, as well as significant hydrocephalus. So what is the cause of her severe bilateral lower extremity weakness? This is bacterial epidural abscess. This is vertebral cocci with epidural abscess. This is a spinal complication secondary to cocci meningitis. This is a stroke. And could this be like CMV myelitis? Wonderful. All right, we have pretty solid responses here, 50-50 to vertebral cocci with epidural or spinal cocci secondary to coccidial meningitis. I think both are reasonable responses, and I'll come back to the patient and we'll see what happened. So she did have an MRI of her lumbar spine. And as you can see here in the bottom, the cauda equina is significantly thickened, and there's quite a bit of adherence of the nerve roots around the cauda equina, very concerning for arachnoiditis, which is the second complication that happens in patients with coccidioidal meningitis after hydrocephalus, which she did have. She did have the hydrocephalus. That was a major complication, but they also tend to have complications with their spine because of the ongoing meningitis. So I'll come back to that. So her serum cocci IgG and IgM by immunodiffusion was positive. Complement fixation was 1:16. And remember, I said sometimes we do see patients with lower level of complement fixation, even with disseminated disease. Her CSF complement fixation titers were significant at 1:32. The PCR was negative. We have about 50% sensitivity for the PCR, so we don't rely on the PCR alone. It has great specificity when it's positive. However, her CSF culture did grow out the cocci immitis. So she was started on fluconazole high dose. She had repeated LPs done, but her opening pressures remained high. So she ended up needing a ventricular peritoneal shunt, which a lot of our patients with cocci meningitis and hydrocephalus end up needing. And despite the shunt placement, despite the antifungal therapy, she progressively worsened, started to develop significant obtundation. Her care was switched to comfort measures only, and she passed. So this was a fulminant disseminated coccidioidal meningitis and arachnoiditis in a patient living with HIV. However, she had good CD4. Her CD4 was greater than 300 throughout. So we do see this. So we do see disseminated cocci involving CNS, even in our patients who don't have apparent immunosuppression. I mean, she's not completely immunocompetent. She does have some amount of immunosuppression. It also probably has to do with her underlying, so some risk factors for dissemination other than immunocompromised conditions that we know of are pregnancy, diabetes, patients who have certain certain ethnicities, racial groups, so African American, Filipino. Even if they don't have underlying medical conditions, they can disseminate, and we see that in our Hispanic patients as well. She was an African American, so it is possible that she had that in itself is actually a risk factor for her to disseminate, even without the underlying HIV. But also comes back to some things on how we can prevent this. So I'll kind of go through some strategies for that. Okay, so what can be done to prevent cocci in patients living with HIV in endemic areas? Give antifungal prophylaxis for all patients living with HIV in endemic areas whose CD4 are less than 250. Screen all patients living in endemic areas with cocci, EIA, or ID annually. Screen all patients annually or twice a year, and give antifungal prophylaxis if they have a new positive IgM or IgG, provided they don't have signs of active cocci and CD4 is less than 250. There's no role for antifungal prophylaxis for cocci in patients living with HIV in endemic areas. All right, you do have kind of like an equal split here, so that's good. And the right answer for this is actually C. Screen patients once or twice a year and give antifungal prophylaxis if they have a new positive IgG or IgM, if they don't have active disease and their CD4 is less than 250. And I'll come to that in a second. So reactive skin lesions in patients with acute pulmonary cocci. This goes back to the first question and how the patient presented with her initial diagnosis. So the common ones that we know of with the reactive lesions are the erythema nodosum followed by erythema multiforme. So the most common immunological reaction to acute valley fever, acute cocci, pulmonary cocci, is this erythema nodosum, which is part of our CAP order set. If you have a patient coming in with CAP, if they have erythema nodosum, consider cocci, test for cocci, right? The second most common reactive lesions that we see after erythema nodosum is erythema multiforme. And I know with erythema multiforme, our fellows usually think about HSV, mycoplasma, but acute pulmonary cocci is also an association with erythema multiforme. And they can have typical target lesions that can also affect their palms and soles. But there are a few other reactive skin lesions that are less recognized, and those are like acute exanthema, which our patient had, and I'll talk about that. Sweet syndrome, interstitial granulomatous dermatitis, which are more discrete rashes that on biopsy can show this interstitial granulomatous pattern. Our patient had what likely was an acute exanthem of Coccidiomycosis. So this is a generalized exanthem, or what we call as toxic erythema. Can occur in about 10 to 12% of patients with symptomatic pulmonary cocci. And when in an outbreak setting, which we had an outbreak of this in California, where 50 to 60% of patients in that outbreak setting actually had the acute exanthem. But typically about 10 to 12% of patients can have this. It usually appears first as like a papular macular rash, but it's typically urticarial, intensely pruritic, and it can persist for several weeks. Now, the eruptions can precede the pulmonary symptoms, or it can accompany the pulmonary symptoms, or it can follow the pulmonary symptoms by a few days. So like in this case, she had pulmonary symptoms for a couple of weeks and the eruption happened after. And clinically, it may be mistaken for allergic contact dermatitis or a drug reaction, because it resembles a drug reaction or allergic contact dermatitis very significantly. So it's important to recognize this, because this, similar to erythema nodosum, when we see this happen in an endemic area, it's important that we test for cocci, especially in someone like her, who's immunosuppressed or is, African American, Filipino. We don't want to miss the diagnosis of cocci in those patients, because we want to follow them for monitoring for dissemination. And that dissemination typically happens in the first 6 to 12 months. So the risk of dissemination in immunosuppressed patients, pregnant patients, patients living with HIV, African-American Filipino population, that risk of dissemination is the highest in the first 6 to 12 months after the acute infection. And that acute infection may be symptomatic or asymptomatic. That's why it's important to screen them, because even if they have asymptomatic infection, they are still prone to dissemination if they have those underlying risk factors. So it's important to catch them and monitor them for dissemination. 2 studies done in immunocompetent patients, there's no role for treating everybody with acute infection if they are asymptomatic. It didn't seem to prevent dissemination. However, in patients living with HIV, especially if their CD4 is less than 250, that's really a risk factor for dissemination. So if you screen them and they are newly turning positive, the next 6 to 12 months, they are at risk for dissemination, and their CD4 is less than 250. If they don't have other risk factors, we would initiate treatment. But if their CD4 is higher, like our patient, our CD4 was a little higher, that's where we really don't know what is the strategy for those patients. So this is one of the unknowns in Cocci is, what do we do if they have more than one risk factor? So I would say in this patient, for instance, the CD4 was higher, but she was also of African-American descent. So she has a higher risk for dissemination. So we do want to monitor them, potentially even start therapy if their CD4 starts to go down. Okay. And the other thing I wanted to point out in this case, of course, she had the main complication, which was the hydrocephalus needing the ventriculoperitoneal shunt, which is the most common complication we see with coccidioidal meningitis. And a lot of our patients with cocci meningitis are prone to shunt failures and shunt revisions. I've had patients who have had 11 shunt revisions, or, but on an average, many of them end up needing 1 or 2 shunt revisions as well. The other complication that can happen with coccidioidal meningitis is that significant fungal burden, the protein burden, circulates around the spinal fluid. So it can lead to inflammation around the cervical, thoracic, or lumbar spinal cord. Arachnoid membrane leads to adhesive arachnoiditis. That adhesive arachnoiditis will lead to tethering of the nerve roots. It will also lead to collections of CSF around the tethered nerve roots, eventually leads to ischemia and infarction of the cord that eventually leads to syringomyelia. So similar to TB and chronic fungal meningitis, it is an important complication in chronic coccidioidal meningitis as well. It's often insidious with variable severity and clinical manifestations. Most cases are subclinical. Most cases are asymptomatic or undiagnosed. When they do have symptoms, it's usually because of nerve root compression. So the most common symptom is back pain, but they can also have urinary frequency, urgency, sensory loss, or weakness in their extremities. So we recently did a study in our center. We had 133 patients with coccidioidal meningitis who underwent spine imaging. So the study was done in patients who had undergone spine imaging, and usually the spine imaging was because they were symptomatic. And those symptomatic patients, 30 out of the 37 in that cohort had abnormalities in their spine. But if you were to check all patients with Coccidiomycosis and do a spinal imaging, it's very well possible that a lot of them may have asymptomatic spinal abnormalities. So the strategy right now to manage is aggressive antifungal management, symptom control for pain relief. It is unclear what the role for surgery or steroids are in these patients. Now, prior to the advent of azoles, we did have significant use of intrathecal amphotericin B, which in most centers, we have moved away from intrathecal amphotericin B since using fluconazole as the first-line therapy. But when intrathecal ampho was being used, there was always this clinical conundrum and dilemma whether the arachnoiditis is from the amphotericin B or is it from the meningitis itself, because intrathecal ampho could also cause the arachnoiditis. In our study, none of the patients had intrathecal ampho. This was a more recent cohort, and we've moved away from using intrathecal ampho for coccidioidal meningitis. This is a couple of our patients, not the patient in the case that I described, but you can see this significant amount of cord edema in cord tethering. And here again, significant, you can see the CSF collections, nerve tethering throughout the cord, where there is, tethering of the nerve roots, adhesion. And so it's a complication that in addition to the CNS symptoms, they have spinal complications and leads to more functional impairment in these patients. Moving on to prevention of cocci in patients living with HIV. again, yearly or twice yearly. So it's hard to tell all patients living in endemic areas to not go out in the dust or not be exposed to dust. It's very impractical. However, we do want to explain to them that it's the dry soil that really puts them at risk. So not to dig into dry soil, or if their occupation needs that they need to be digging to wet the soil or to use masks. So these are some counseling methods that we can give them, but it's impractical to avoid dust for these patients when their occupation needs that they need to be exposed to dust. So for patients living with HIV in endemic areas, it's reasonable to do a yearly or twice yearly serological testing, and both IgM and IgG antibody testing using either an immunodiffusion or an EIA is recommended. And in patients whose CD4 counts are less than 250 and who previously tested for negative for Cocci, because we're trying to catch that new infection, because it's that new infection that puts them at risk in the first 6 to 12 months for dissemination or more severe disease. So if they have a new infection suggesting of a possible active disease, we should do further clinical evaluation, make sure they don't have active symptomatic disease. So if they don't have any signs, symptoms, or lab abnormalities that's compatible with an active disease, we should consider antifungal therapy. And this therapy can be continued until their CD4 count is about 250, virological suppression is documented. But even after that, it's very, very important that we retain them in care for both the HIV and the valley fever, and make sure that we continue to monitor their valley fever titers and continue to counsel the patients about symptoms of disseminated disease, whether it's back pain, bone pain, skin lesions, or headaches, so we can identify those early. So some key points from these two cases, I would say, in the initial phases of infection, complement fixation, immunodiffusion, EIAs, all of them can be negative, especially in immunocompromised host. Retesting as well as empiric treatment becomes important to avoid delays in diagnosis and treatment. Reactive cutaneous lesions in acute pulmonary Cocci, in addition to erythema nodosum and erythema multiforme, can include diffuse exanthems, which may last for several weeks and can be mistaken for drug reactions or contact dermatitis. This becomes especially important because a lot of our HIV patients are at risk for allergic reactions too. So we do mistakenly diagnose them with allergic reactions to either their heart or their co-infection treatment, whether it's for MAC or other medications. So it's important in endemic areas to remember to put in acute pulmonary Cocci when they have these cutaneous lesions that come up. And we do want to screen all patients living with HIV in endemic areas for Cocci with Cocci EIA or immunodiffusion once or twice a year, and give antifungal prophylaxis if they have a new positive IgM and or IgG with no signs of active Cocci, especially if their CD4 count is less than 250. If their CD4 count is above 250, I don't think we quite know if there is a role for prophylaxis, but if they have other risk factors, whether it's their underlying racial risk factor, or if they have other comorbidities, again, we want to watch them very closely. I think that's all I have. I do want to acknowledge our lovely HIV and ID division faculty and fellows who actually do a lot to take care of these patients at UCSF Fresno. Thank you.
Thank you so much. Those were extremely interesting cases. Any questions from the audience?
Thank you so much for the talk.
Sure.
So I had a question. I remember a paper that was published, I can't remember how many years ago, but it said that about 30% of CAP in endemic regions was attributed to Cocci. So I'm wondering what your estimated rate of the prevalence is now and how common empiric treatment is among general practitioners. I imagine urgent care providers or ED physicians are probably most likely going to see these patients first. So
yeah, no, that's a great question. That's a great question. And I don't think we actually know the true incidence, because a lot of them, you would expect in an endemic area that a lot of the CAP patients are getting tested. But unfortunately, we found from recent data, both in California and Arizona, that urgent care providers, primary care physicians are not testing for Cocci. More than 2/3 of Cocci diagnoses are made in the hospital. They're not made in the office settings. So that's definitely a room for improvement. And we do estimate about 30 to 40% of CAP cases in endemic areas are actually from Cocci, but that probably is higher because we are not testing them as much as we should be. Thank you.
I think I can use this. Thanks. Thank you for a great talk. Just wanted to ask your thoughts a little more on antigen testing. Here at UCSF, we've been doing more of that in conjunction with the serologic testing options, just on the theory that all of them have sensitivity problems, and maybe by adding in antigen testing, we just get more additive sensitivity. Just wanted to know your perspective on that.
Absolutely. Yeah, I think we've not used antigen testing in our center. I think it's more of just a culture of not being introduced to that antigen testing that much. But I do think it's a great test for immunocompromised host, not by itself, but as an addition to culture, histopath, and molecular methods, especially if they're severely ill. And it is available from CSF, serum, and urine. There is some cross reaction between other endemic mycoses, but based on the clinical suspicion, we can tease that out. But I do think there's a great role for it in immunocompromised hosts.
So I always think it's interesting, the guidelines for people living with HIV in endemic areas. And I think we always struggle with what does endemic mean. Right now, here we are in San Francisco. We certainly see plenty of Cocci cases, although we don't consider ourselves, we're not in the valley, but I think we've all seen people be exposed and have disease without that sort of classic history. What is your advice to California towns like San Francisco when we're seeing people with a T cell count of under 250? Have you advised people to do the screening yearly, biannually for serology? I think many of us don't do that, but it is just a good reminder because we certainly still see Cocci. So I think we all struggle a little bit with this when we're not exactly endemic, but we certainly see it.
Absolutely. And that's a great question. And I do think the geography of the endemic mycoses are changing. So we don't actually want to even call them endemic mycosis anymore. So most of our fungal infections, we are changing the terminology because the geography is definitely changing. It is moving north, it is moving east. So I don't know the answer. I don't think we know what is the strategy in places that are not hyper-endemic. The problem is even in the endemic areas, we are not actually screening. So it's all around us, but we've kind of developed this blindness to it, I feel like. So I do feel we may need more incidence testing in this area to see what the general population incidence is. And if it is creeping up, and then I think we should start screening here as well. Thank you.
Thank you for that fantastic talk. I was just wondering how commonly you encountered treatment failure on fluconazole, and I think that obviously it's different depending on what manifestation. So I'll sort of leave it open, but and how often you end up sending resistance testing, if at all.
So great question. We do encounter a lot of fluconazole failure, especially in our coccidioidal meningitis patient who need the long-term therapy. So in our study recently, the rate was almost close to 30 to 40%. And to some extent, it's especially in the CSF, fluconazole is not, it's not cidal, it's static. So we see patients coming back 10, 15 years later with VP shunt failures, and we culture their shunts and we are growing Cocci while they've been on treatment for 10, 15 years. So it's definitely a problem, and we do end up switching agents. And in terms of antifungal resistance testing, a lot of the monitoring that happens for Cocci is through the complement fixation titer. So we actually are not able to get those culture specimens outside of coccidioidal meningitis. So in meningitis patients, we are able to send it for fluconazole resistance testing, but non-meningitis patients who have disseminated or chronic pulmonary Cocci, the treatment failure definition is based out of either symptom management or their radiological findings, or their CF titers are not coming down, and we end up switching therapy. Typically, it's roll the dice between one of the other azoles, and each patient is different and responds better to one azole over the other. And if we have cultures positive and they've been on adherent to their medications and their levels are good, we do send fluconazole resistance testing for those. Great questions.
All right. Thank you so much. That was
course,
a great
thank you.
talk, and thank you for making the trip.
Of
Thank
course.
you.
Yeah, it was my pleasure. Thank you.